Good morning, everyone, and thanks for the opportunity to join you at your community conversations about the side effects of prostate cancer. I'd like to thank the PCFA for this invitation. It can be very difficult to work out the true impact of being told that you may have a cancer. Much of that initially is a psychological upset. I'm certainly no expert in this area, and you do have a couple of very good speakers to follow covering the psychological impacts of this. As a urologist, though, I need to be aware that the moment this issue is discussed, there is a lot of anxiety, and therefore the ability to assimilate information that has to be delivered can be difficult for the individual patient. It's therefore always a good idea to bring someone with you to these appointments so they can hear what is being said and the true impact of some of the uncertainty. The areas that one needs to cover in terms of side effects includes the psychological aspect, because that starts from the very beginning and carries you through the whole treatment cycle, and even can be an issue years and years later when ongoing uncertainty or upset or regret can exist. But specifically this morning, I should cover the urinary dysfunction, the sexual dysfunction, and the metabolic dysfunction. The metabolic dysfunction are those things that occur to us from treatment that can make us feel a little unwell or tired or worn out without actually feeling sick as such. It can begin with the PSA test because it's not really a cancer test. We use it as that to look for the activity in the prostate, and that activity is usually prostate cancer. But there are numbers that we use that may not always make sense in terms of why there are certain cutoffs and why it might mean something above that line and below that line. And some of that is confusing because an abnormal PSA can mean prostate cancer, but it may not exist. And equally, a normal PSA, so-called normal PSA, can be present even though prostate cancer is there. So the confusion can start fairly early on. Then when one visits the urologist, a rectal examination is performed. It's not an unpleasant examination, but there's a lot of folklore about this and a lot of jokes, and I think people have preconceived ideas. And some people, even out of fear, will just not begin the process because they don't want to have anything invasive. There are other things that are done these days. They include scans. An MRI scan is a magnetic scan that looks at images of the prostate and gives us a risk profile of the prostate. It doesn't always tell us that prostate cancer is there, but it lets us know whether we should investigate that man further. But it's a test that has to be done. It's time-consuming and can create more uncertainty. Then, if there's ongoing doubt, a biopsy is organized. This is taking samples of the prostate. The images can be quite confronting, even though one can explain that this is done under full anesthetic in most situations, so you don't feel the procedure as it's done. But there will be some discomfort, swelling, bruising, and bleeding that can follow afterwards for a few days. But most men make it through this without any upset. However, the thought of having it done can be quite frightening. Once the result is known, if there is a prostate cancer there, then it's difficult to know whether this can be cured. Sometimes one can be fairly certain that cure can be achieved. At other times, it can be a little difficult to know because the cancer may be very close to the margin of the prostate indicated by the blue line. And at other times, there might be good evidence either before the treatment or after the treatment that the lining of the prostate or the margin of the prostate has been breached, and therefore the cancer has spread beyond what is known as confined disease. This will require additional treatment. Along the way, other types of scans are helpful to look for spread of prostate cancer. The PSMA PET scan is commonly used now. It is often done as a precaution, but there can be anxiety and worry about what that result might indicate. And often, as we all know, the test is done and the result is not available for some time until a follow-up appointment is done. Some people take that as bad news, and others accept it as one of those logistical issues to deal with. Sometimes a bone scan is done. This looks for spread of prostate cancer into the bones. And again, because of folklore, sometimes this is considered bone cancer, which is a different type of cancer. But whatever it is, if it's involved, it is thought to be a bad thing. And until that clarity is achieved, it can be a confusing time. Then when treatment is offered, it can be difficult because there are a number of treatments that we can offer patients, and this is where the urological side effects come into play. In terms of preparing for the operation, there's no question that there are a number of things that can occur, illustrated on the left-hand side of the screen, that can occur with any type of operation. On the right-hand side are more specific issues, in this case erectile dysfunction, and what I say to men is erections as you know them now will change. They will be weaker or non-existent and may require treatment to improve function. The waterworks do certainly get upset. There can be leakage problems, unpredictability, difficulty with stream, and general upset about the waterworks that can be bothersome in a significant way. In addition, as I've mentioned, the treatment can be offered, but then that can be residual prostate cancer requiring further treatment, which comes in the form of radiation treatment. There can be other minor issues that occur during the operation. Some of them can be serious but are rare. They're usually recognized and sorted out at that time. The ongoing problem is the need for PSA tests for the life of that patient to check for recurrence of prostate cancer. If we go down the path of radiation treatment, then that involves daily treatments for usually 4 weeks. That's done as an outpatient treatment, but that too can cause bladder and rectal irritation with upset of function of the bladder, as well as the back passage, where we get frequent voiding or frequent bowel motions. Sometimes that can be significant. For most people, it's a minor bother, but again, it does impact their quality of life. With radiation treatment, the sexual function does also get affected. Erections can be weak. And this is more so because quite commonly hormone suppression or testosterone suppression therapy is used to weaken and shrink the cancer. And when that happens, libido drops as well, and there are a number of other side effects which I'll come to shortly. These will involve tiredness, hot flushes, depression, weakening of the bones, and any number of issues with the body, including weight gain, shortness of breath, penile shrinkage. And as you look at that list, you can see that many of those things may not make you sick, but can make you feel unwell in some way, and certainly can lead to mood issues that can affect your quality of life quite significantly. Another form of radiation includes brachytherapy, where radioactive seeds are placed into the prostate. This involves a couple of visits to the operating room to measure the prostate and then to place the seeds, but it too can offer its own share of urinary and sexual dysfunction. It appears that no treatment one would offer would give you a free rein into the future without some type of side effect to affect your quality of life. Then when the cancer is done and hopefully cured, you would think, well, that's great, I'm done. But as we've heard, there will be side effects, and let's cover some of those now. Post-treatment urinary incontinence, particularly with surgery, is fairly common. Usually it's mild, and usually it gets better over time. But there is a period during that time when one can feel that the leakage problems are quite significant and not looking like they're going to get better. There are a number of treatments that can help from the very beginning, even before treatment is offered. Pelvic floor training by a specialized service, including a nurse who's trained in this area or a physiotherapist, can be quite helpful even before treatment is offered, and is best, in fact, delivered at that time. This is to strengthen the pelvic floor before any operation or treatment is offered, so that you know what you're trying to do rather than trying to do it once it's all started. Less so, we use things called bulking agents, which I'll cover shortly, and a variety of slings or sphincter mechanisms to increase our continence or ability to hang on to urine. This slide illustrates bulking agents. This is where we place a little telescope down the urethra under an anesthetic, known as a cystoscope. Through that we can see the neck of the bladder, which is the top left picture that you're looking at. And then we can pass a little needle and inject a thick solution into that area known as a bulking agent to cushion that area as best we can. And as you can see on the diagram, that's how that's done. It's a day procedure done under a general anesthetic. What we're trying to do there is inject at any location. It can commonly be at what we know as the 6 o'clock position, the 10 o'clock position, and the 2 o'clock position to achieve complete bulking and closure. Another treatment is mesh or sling surgery, where we create a U-shaped loop to support the urethra, which is the blue structure in the middle, and you can see the mesh looping around to support that and then lifting up into the body to help with continence. A different type of sling is known as the atom sling. This is an adjustable sling. You'll see that there is a cushion that sits at the lower end of the urethra, and that can be adjusted through a titanium port that's implanted into the body of the scrotum and can be accessed by a small needle. The idea of that is it puts pressure on the urethra, so when you cough or sneeze, it is harder for urine to leak out. There are, however, early and late complications from all these types of surgery. They include bleeding and bruising, some issue with the sling, some type of injury to the structures nearby, as well as some type of waterworks issues, maybe too much slowing of the stream and inability to empty. And the most worrying is infection of some sort, which if serious may require hospitalization and removal of the implant. Late complications include ongoing problems with the urethra tube, some type of pain that just isn't being resolved, ongoing incontinence despite surgery, as well as infection and need for adjustment or need for other types of corrective surgery. So there can be ongoing regret about decisions made and ongoing upset about the problems that have been generated by the original treatment. If the leakage is quite severe, we would often recommend an artificial urinary sphincter. This is a donut type cuff that's placed around the urethra to compress it, and it is supported by a reservoir in the tummy, and through tubing structure a little pump in the scrotum which one has to press to void, and then it will refill itself automatically. But you do need to press the pump every time you void. As one gets older and forgetful, that can be a little bit of a problem. If you're having operations where a catheter needs to be placed, for example a hip or knee surgery, then the sphincter does need to be left open and deactivated while the catheter is in, and a urologist needs to attend for that. It's important that you wear a medical alert type bracelet when you have one of these to alert an orthopedic surgeon, for example, that this needs to be done. Again, with this type of surgery, there are potential issues very similar to the other: the bleeding, the swelling, the injury to the structures, infection, waterworks problems, and if serious, the device will have to be removed. In the latter part of the stage of how this goes, assuming it's working well, there can still be some little issue about it that you're not happy about. It can erode into the urethra over time. The incontinence can either continue to exist or recur, and there can be leakage that follows. In 1 in 4 men over a 5-year period, leakage will recur, and in 1 in 2 men, it will occur over a 10-year period, and therefore it's not forever. That too can lead to regret and expectations that have been failed to be met. Another side effect is erectile dysfunction, as I've discussed. This can occur from any type of the treatment that we've offered, the surgery, radiation, or hormone suppression. And I guess let's not forget that sexual function can be severely affected by the psychological impact of whatever else is going on. We tend to treat this with counseling and low-dose treatment of what is known as Viagra or Cialis. They're commonly now available as a generic medication and therefore cheaper. One will take a low dose on a daily basis and then a top-up dose when sexual activity is planned. If that doesn't work, then injection therapy can be progressed to. That's commonly known as Cavaject or Trimix. We teach you how to place a small needle into the body of the penis and inject the medicine directly into the penis. This gives you a very good erection. It's far more reliable than tablets, but does require you to learn how to do this, and some men find this off-putting. Your partner can naturally assist, but it requires both you and your partner to feel comfortable that this is a reasonable way to go. Further to that, one could try vacuum devices. This is where a vacuum device is placed over the penis, a pump mechanism is created to fill the penis with blood, and then a ring is placed over the base of the penis to maintain the erection. It's a non-pharmacological treatment and does not involve needles, and for some men who are getting soft erections who want to strengthen them, this would be a reasonable way to go. Another type of treatment is known as penile implant surgery. This is where 2 silicone tubes are placed into the penis, and they can be activated by a scrotal pump, again using a reservoir type system. And you can see the top right picture where the penis is flaccid, and the next picture where it has been pumped for use. Once sexual activity is completed, the penis can be deflated. This is an internal diagram of what that looks like with the two cylinders inside the penis, the pump in the scrotum, and the reservoir that's hidden away. Often the reservoir cannot be felt. Some of the tubing in the scrotum can, as well obviously the pump, and the cylinders within the penis can be felt as well. This is an image of an implant that was done at a 6-week mark. There is a slight bulge in the scrotum where the pump is sitting. You can see that it's fully hidden, and quite a satisfactory erection, without needles, without tablets. It has obviously advantages. It's fairly low complication surgery with highest patient and partner satisfaction rates, as long as both are happy to go down this path. The device can malfunction, but it's a fairly low rate over a long period of time. Other things include the freedom from medication and supplies, to 2-night stay in hospital, and the ability to resume sexual activity 6 to 8 weeks later, and no loss of ability to achieve orgasm. There are obviously disadvantages. The bruising and swelling initially, what I call the first 2-week blues, where you can have significant amount of regret about going down this path because you can't really see the result that you're looking for. It's all coming in the future. Recovery takes about 6 to 8 weeks before the device can be used. It is not available through the public hospital system in most areas, and therefore there is cost, even if you carry private health cover. The infection rates are arguably significant, from 2 to 3%, and if they do set into the implant, often it needs to be removed, and a lot of dissatisfaction about that. There can be some type of mechanical tubing issues or some issue with the implant that one is not entirely happy with, requiring revision surgery and therefore further cost. It is better than where one would be at the time of making the decision, but never as good as the original penis in terms of length, girth, or fullness, and therefore that too can lead to some regret about the original decision. It's all about expectations and where one goes with this, not just with sexual function, but with all aspects of the treatment cycle. So I hope that's been a good thumbnail sketch for you, covering some of these areas. I wish you well for your meeting, and hope you get a lot out of this process.